component of restrictive lung diseases has to do with chest trauma. The main point here is that there are a variety of different kinds of trauma that can produce a restrictive condition on the lungs. So if you think back to what we've discussed so far, we've discussed conditions that are obstructive in that they prevent blood flow or oxygen, air from exchanging into or out of the lungs by nature of the structures and the diameter of the structures of the lungs. In this case, we're talking about conditions that produce a physiologic restriction on the lungs so that whether air can pass into those tissues or not, or those structures, it can't expand. So the number one restrictive lung condition resulting from chest trauma is pneumothorax. I say number one, probably the most common of the others. Now, pneumothorax can be a result of a penetrating chest injury, such as any kind of sharp object, that being a knife, a stick, traveling with enough force, a gunshot, like a bullet. Anything that has the capacity to penetrate the chest can produce a pneumothorax. And I also don't want you to limit this only to trauma that is a result of violence or accident. You also have to consider that surgery is a planned trauma. Also, insertion of triple lumen catheters are a planned trauma. So pneumothorax can result from anything, any traumatic event to the chest that is penetrative in nature. So blunt force trauma to the chest, such as being hit with a bat or falling downstairs or skiing and hitting a tree. Obviously, those are blunt injuries. Those can produce rib fractures. Rib fractures alone can be uncomfortable, can limit breathing, can make it uncomfortable for someone to take a deep breath. However, rib fractures can produce sharp, splintered type aspects to the ribs themselves, which can then puncture underlying chest tissue and produce a pneumothorax. A flail chest is a result of multiple rib fractures. In this case, what it ends up producing is a lack of structure to the chest, so that the chest is very free for expansion and movement, which may sound like a good deal. However, what results is a decreased capacity to expire. We need that thoracic recoil in order to help facilitate exhalation. So flail chest can produce its own set of problems. Sternal fracture would be a fracture of the sternum itself. This would require a great deal of force. It's a very thick, dense bone in most cases, unless, of course, someone has a condition that makes bony structures more brittle. But sternal fracture is a high force to the chest that can produce trauma, of course, to the lungs, but also to cardiac tissue, which sits directly under the sternum. This was a common cause. Sternal fractures were a common cause of fatalities in car accidents, which led to the development of airbags. So thank you very much that we see very few or much fewer sternal fractures than we did in the past. That force of the chest crushing into either the steering wheel or the dashboard could be enough to fracture the sternum. Pulmonary contusion is another result of blunt force trauma, which in and of itself is not a penetrative injury producing pneumothorax and not necessarily restrictive. However, what a pulmonary contusion is basically a bruise to the lung tissue. So this would be commonly small areas of bleeding, like a bruise under the skin, that causes that portion of the tissue to be weak when it tries to move, or relatively ineffective and produce focal edema, localized edema in the area of the contusion. generally a result of blunt force trauma, someone being assaulted, motor vehicle accident, for example. So that can also produce a degree of restriction to the capacity to breathe, but generally pulmonary contusions in and of themselves do not pose enough of a challenge to produce a really restrictive compromise to the patient. I've alluded to already penetrating chest trauma, such as knife wounds, gunshot wounds, or even surgical trauma. Now, in this case, when a penetrating injury occurs, there is likelihood that you are going to have injury to the vasculature as well. So that's why I mentioned here hemopneumothorax, because in addition to rupturing that pleural lining and allowing air to move into that space, generally penetrating trauma is indiscriminate in that it doesn't choose to just puncture tissue and let air into the space. It is indiscriminate. So vascular injury is going to happen as well, which is going to allow blood to move into this space as well. So hemopneumothoraces are another significant chest trauma that can produce a restriction. Also, cardiac contusion. I've alluded to this just earlier when I mentioned trauma from a steering wheel to the sternum. We're talking about sternal fracture. Cardiac contusion is essentially a bruise effect to the heart, which can produce essentially a comparable effect to a myocardial infarction, in that the heart can be so stunned from that blunt force trauma that portions of the heart can fail to function appropriately and can, in fact, infarct as a result of that trauma. So cardiac contusion in and of itself is nothing to disregard. We have to take that quite seriously. As a result of cardiac contusion, another problem that can pose an issue to the lungs is cardiac tamponade, which is where blood fills the sac around the heart, pericardium, and may produce that restriction. And my note here may be caused by, that can be caused by either a penetrative injury or a blunt force trauma to the chest. Either one of those can produce a cardiac tamponade. The other condition that can produce a cardiac tamponade is any kind of rupture or erosion to the myocardium that results from the inside. That can happen. I have seen this occur with patients who had a defibrillator lead that needed to be changed, and when the lead was removed in the EP lab, it brought with it a significant portion of the endocardium, which caused a vascular emergency. The patient was bleeding into their pericardial sac, and that became a cardiovascular surgical emergency. So that is entirely possible. Subcutaneous emphysema is another condition that is a result of chest trauma. It's less common that subcutaneous emphysema produces a restriction on the lungs, commonly because the emphysema, the air, is in a space between the lung and the skin, and there is enough structure within the chest wall to prevent that air from compressing or limiting pulmonary function. Subcutaneous emphysema commonly rises, so you'll generally see this above the nipple line, higher in the chest, sometimes even and often up into the neck and face. It is very unappealing to look at when patients have it. They don't appreciate their face being all puffed up. But once the puncture where this has originated has resolved, the air will ultimately reabsorb and the condition will correct itself. So pneumothorax, I've already discussed this a bit, but just to reiterate, it's air in the pleural space. So it is a result of a spontaneous rupture in that pleural space. So the tissue of the lung itself creates a small opening that allows air to pass into the space between into that pleural space, that lining around the lung that is a potential space, but once filled with air, compresses the lung, and that portion of the lung can be inflated. And that can be anything from a small portion of the lung to the entire lung itself, producing a complete collapse of a lung. So spontaneous pneumothoraces, by definition, is one that happens without any kind of extenuating circumstance, such as trauma or injury or fall or anything such as that, or no known lung disease. This is more common in the young male population during their growth spurt. So late adolescence is the common demographic for spontaneous pneumothoraces, but that doesn't mean it can't happen in other demographics. It just occurs there most frequently. And the treatment for pneumothoraces is the same, regardless of the pneumothorax. There is a slight change for tension pneumothorax, and we'll mention that when we get there. But essentially what we have to do is create the environment for the lung to reinflate. So we've talked about spontaneous pneumothoraces just now, and we've also already discussed trauma. Internal trauma would be trauma from a rib fracture that's punctured the lung, versus external trauma, which would be such as a stabbing or a gunshot wound or falling on a sharp object that penetrates the chest, or such as in an explosion or some kind of severe storm, an object moving, what we would consider a dull object moving at a high rate of speed, yet its surface area is small enough that it could penetrate the soft tissue of a human body. All of that could be considered external trauma. Procedural would be something like what I mentioned earlier, such as insertion of a central line, or performing a thoracentesis or bronchoscopy. Any of those procedures in and of themselves could produce a puncture to the pleural tissue and create a pneumothorax. Certainly not intentionally, but just it's one of the inherent risks of those procedures. We've discussed violence, someone being assaulted, stabbed, shot, all of those things. And of course, accidents such as motorcycle accidents, motor vehicle accidents. Most objects in a car are not considered sharp, but a blinker, for example, blinker is it's a relatively small object with enough force applied in the right direction that could be and create penetrating injury. So there are pathologies such as COPD and cystic fibrosis, pneumocystis, mechanical ventilation, ARDS, a condition called BOOP, B-O-O-P. We won't get into that, but all of those conditions can affect pulmonary tissue and predispose a patient to pneumothorax as a process of moving through the recovery process. So those populations are more susceptible to the potentiality of developing a pneumothorax. Mechanical ventilation may not seem intuitive as a potential cause for pneumothorax. However, you consider that mechanical ventilation, as we've alluded to earlier in class, is a mechanism wherein oxygen is delivered to the human in a way opposite of the way we normally get oxygen into our bodies. Remember, we draw, with negative pressure in the chest, we draw oxygen and air into the lungs. With mechanical ventilation, we're pushing that needed air and oxygen into the lungs, and that forward force can be traumatic and injurious to the lung tissue and create a pneumothorax. So often is the case in ARDS that patients develop pneumothoraces as they begin to improve, because there are portions of the lung that are still very sick and need the higher pressures associated with mechanical ventilation. However, there are portions of the lung that are recovering, and those portions that are of the lung that are recovering from the illness, but yet weakened from the illness in the recovery process, so they're not as strong as they normally would be, and that higher pressure that's needed to ventilate the other alveoli can produce a puncture in the healthy or recovering alveoli. So just know that pneumothorax is a potential side effect, complication of mechanical ventilation, and these pathologies can be susceptible to that. Tension pneumothorax is a specific type of pneumothorax that is greater in severity and criticality than any of the ones alone that I've mentioned above. Now, any of the ones that I've mentioned, any cause of pneumothorax can produce a tension pneumothorax. Tension pneumothorax is an escalation in the severity of that pneumothorax. So here what I mean by tension is there is sufficient air and pressure in that pleural space that it creates tension on the major other organs in the chest, specifically the heart. When the heart begins to shift as a result of these pressures, then tension is placed on the major vessels. There's not a lot of latitude for movement of the heart within the chest itself laterally from side to side. Of course, there's room for the heart to contract, but for the heart to move either to the right or left, there's not a great deal of flexibility there. When the heart shifts, you create a compression on the superior vena cava and the aorta, and that tension then creates a severe cardiovascular hemodynamic complication and problem. So a tension pneumothorax usually results in a shift of the heart to one side or the other. The one key diagnostic piece that makes this evident is a midline shift of the trachea. So when you look at the person, when you look at a patient, everyone you've seen to this point most likely has you can see their cricoid bone in the center of their throat, which indicates the trachea's midline, and you even note this in your assessment findings when you're validating on assessment. When a tension pneumothorax occurs, the trachea will shift to the side away from the area of the pneumothorax, because here again, not only is the heart being placed under tension, but the major airways in the chest are also being placed under tension. So we can also develop some issues with respirations in addition to hemodynamics. So you could see where a tension pneumothorax could be is a highly critical state. In this case, tension pneumothorax is addressed with needle decompression at the second intercostal space on mid-clavicular line on the side of the pneumothorax. That will then relieve the pressure temporarily until a chest tube can be placed. Hemothorax is similar in effect to pneumothorax, but the cause is different. With hemothorax, simply stated, there's blood in the pleural space. That blood then is displacing lung tissue, compressing lung tissue, and preventing it from inflating. Obviously, the greater the hemothorax, the greater the distress by the patient. Both hemothoraces, pneumothoraces can create emergency conditions, and chest tubes can need to be placed quickly. The location of the pneumothorax and the hemothorax determines the placement of the chest tube. As a general rule, the pneumothorax is going to be placed high, and the chest tube for the hemothorax is going to be placed low. This picture is a cartoon graphic representation of a collapsed lung as a result of a pneumothorax. And you can see in this image, there is a space around the lung. This would be considered a pretty severe pneumothorax, regardless of the fact that there is space below the lung, as demonstrated down here on the bottom left side of the patient. The chest tube would be placed high. so that the air could be evacuated. What will happen is as the lung reinflates, this air under the base of the lung will be pressed toward the apex of the lung and then fully evacuated. These next two pictures demonstrate the conditions we've been discussing. So as you can see in this first image, what we have is a tension pneumothorax. Now, the way we know that this condition is under tension is the simple fact that the right cardiac border is shifted here to the right. I reference the right because I'm speaking in terms of the patient's right. So if you notice here where I'm tracing my arrow, that is the right cardiac border. This is actually a portion of the aorta that's being shifted over, as in addition to the superior vena cava being pressed to the patient's right. At the bottom portion down here in the bottom ribs, this is the inferior wall of the heart being shifted also to the right. And you can see that the left sternal border of the heart is also moved. So in this case, this patient's cardiovascular system is under tension. And you can also see in this picture, the trachea is also deviated to the right. In this case, we would, at the mid-clavicular line, second intercostal space, insert a large bore IV to evacuate the air, which would allow everything to move back to the center. Then we would have time to we would then stabilize the patient and have time to insert a chest tube in a much more preferable hemodynamic state. This bottom picture illustrates a hemothorax, and you can see this hemothorax is represented by this opaque area just below the arrow. The arrow is showing you the meniscus of the blood in this patient's chest, and you can see that the lung field is compressed. You can obviously see it compared to the right lung field. The left lung field appears much smaller. There's not less lung tissue. It is just compressed as a result of this blood that's accumulated there in the chest wall. And this last picture here you see is a very severe pneumothorax. And in this case, this patient's vasculature, despite the severity and the profound nature of this pneumothorax, this patient's chest and thoracic organs are not under tension. So you will notice the lung fields here on the right of the patient are very clear and dark. So if you'll note here between the intercostal spaces, it's very crisp and clean. If you look at the left lung fields, you can see evidence of the vascularity here, these little spidery looking white areas. That's the vascularity here on the left-hand side. You notice that vascularity is missing on the right-hand side. That's because that vascularity is around lung tissue, and that lung tissue is collapsed into this small place that looks like a tumor or something here inside the patient's chest. I also want to call out in this image, you can see the arch of the aorta right here where my arrow is tracing. It is in the center of the chest, just slightly left of the sternum, which is where it belongs. You can also see the left cardiac border is in the relative center of the chest, so that this organ in the heart is not shifted far to the left. And you can also see that the patient's trachea is midline. So this is a severe pneumothorax that's not under tension, as opposed to this first image where you can see the organs shifted. The treatment for both hemothorax and pneumothorax is going to involve a chest tube. And even if we do a needle decompression, we're ultimately going to place a tube in the patient's chest. For a pneumothorax, typically those chest tubes are smaller in nature and insert or dwell around the second intercostal space. They may be inserted into the actual chest in a lower location and then tunneled up or advanced up to the area of the pneumothorax. A hemothorax is characteristically going to involve a chest tube for a hemothorax is characteristically going to involve a larger tube placed lower in the chest and commonly posteriorly at approximately fourth intercostal space and resting low enough to evacuate the fluid. The reason the tube is placed lower is because obviously fluid moves subsequent to gravity to a lower location. And also patients tend to be on their back in think of a semi-Fowler's position, where the fluid will tend to move posteriorly to the back of the chest and lower toward the lower part of the thoracic cavity. So for that reason, that's where we'll place a chest tube for hemothorax. We need a larger tube because in the case of hemothorax, we're evacuating blood, whereas with a pneumothorax, we're evacuating air. We need something thicker, larger, that will handle the viscosity of blood. Commonly, the chest tube device is set to 20 centimeters of water seal suction. That setting is set on the device. You will see this little orange arrow here, which I will show you this in class if you haven't seen it already. If you're listening to this after class, you will have already seen it. That little orange indicator points to the degree of suction. The wall suction is set to maximum. You turn that all the way up, and the regulation of suction happens in the chest tube container. This is a management issue. I hate to say symptom management because it is part of managing the consequences of a hemo or pneumothorax. We still have to treat the problem. You've heard me say this multiple times already. So dependent on the cause depends on the solution. Spontaneous pneumothoraces are generally treated with a chest tube and given time to see if that pneumothorax will resolve. Commonly in healthy tissue, it will, once that pneumothorax is decompressed and the lung reinflated, it'll heal on its own. Fractures the chest may have to be splinted with tape or a brace of some sort in order to prevent the fractures from moving and continuing to penetrate the chest. If they're serious enough, then fractures and penetrating trauma may have to be addressed surgically to repair any of those problems. If there is a disease process, then of course we're going to manage that condition, such as cystic fibrosis, COPD, pneumocystis, as we mentioned earlier. Now, there may be a state in which the pneumothorax or hemothorax does not resolve on its own. A hemothorax is a vascular issue, so that will require vascular repair if it doesn't heal. A pneumothorax may require a condition called a pleurodesis, which is an interventional procedure, a minor surgical procedure in which the tissue under the chest wall on the top side of the pleura is abraded to create inflammation. And this can be done either with talcum powder, antibiotics, which is a more common approach these days, or with an instrument. Once the tissue is abraded and irritated, it becomes inflamed and begins a healing process of created adhesions, which causes the pleural tissue to be adhered with these adhesions to the chest wall and seals the area around the perforation, much like fixing a flat. So that obviously depends on the way the patient responds. This middle picture that you see is a representation of the chambers and how they function in this chest tube apparatus that you see in the far right. So I will move from the patient. So the chest tube from the patient is connected to the container, which is where air and blood can move into the wells of the chest tube container. And you can see that essentially these containers are one big container, which are segregated to allow fluid to accumulate until it reaches the top and moves through this, and then it begins to fill the next chamber. This helps us monitor volume coming from the chest. You notice this opening allows air to pass across in the event of a pneumothorax. So it allows the air to move across these 3 chambers. And then this moving now to the far left of this container, you notice there's a blue area where you see these little blue dots rising up. This is where water is filled into the chamber, which creates a water seal. And that's what you see in this second chamber here. As the fluid fills this, the some migrates into this chamber, which creates a water seal right here, because the opening allows, this opening here where this yellow arrow is, allows air to evacuate, as represented by these bubbles, allows air in the case of a pneumothorax to evacuate through the water seal and leave, so it's not contained in the system and is drawn out by the suction, because this top port is where wall suction is connected to the device. And within this chamber is where this dial that I pointed to earlier lives to create this 20 centimeters of suction that's being applied in this area that is ultimately directed toward the patient's inside this whole canister, which is what the patient's chest wall experiences. So nursing management, safety is our prime concern. And in this case, aside from the normal safety issues, falls and those sort of things, we have to make sure that the patient is safe, because from any kind of potential injury as a result of this tube being inserted in their chest. So in that case, we have to make sure and continue to reassure that all connections are continuously secured and functioning. That prevents invasion of bacteria and other forms, anything that could potentially produce infection. It also prevents any inadvertent escape of air either out of the patient's chest or into the chest wall and perpetuate our problem. Also, we have to keep the patient away from the tube themselves. So in addition to all the connections being secured and suction being maintained and the suction being connected appropriately and regulated appropriately, the tube has to remain in the body and maintain this whole therapeutic intervention. If the tube becomes dislodged, that can worsen the problem we've been trying to fix, as well as produce additional injury to the patient. So we have to make sure that we as staff don't inadvertently catch the tube on something and discontinue the tube, or give the patient the opportunity to get a hold of this tubing and inadvertently or intentionally even discharging it. So a great deal of caution here is required when repositioning the patient, moving them in bed, moving them to the restroom, moving them from room to room, or moving for procedures such as CT scans or MRIs. And also, as the patient is in those tests, as the table moves, that there's plenty of slack to provide room for that tube to move so that it doesn't get caught on something as a part of the testing process. We have to monitor output. We definitely need to keep up with how much fluid is coming out of this and at what rate. How many cc's every 4 hours or every 8 hours, depending on how, or potentially even every hour or 30 minutes, depending how rapidly fluid is evacuating from the tube. We want to continually monitor respiratory pattern and oxygenation. So patients' ventilation and oxygenation are imperative here. Both of those can be impacted by the pathology of either hemo or pneumothorax. So we have to be attentive to respiratory pattern and oxygenation, as well as how the patient feels and looks. We're going to be monitoring the system for air leaks, which I've alluded to earlier. We also are going to be monitoring the patient for any bleeding, both within the tube and around the tube at the insertion site. So there is the chance that bleeding can occur around the tube, and we need to be attentive to that. Now, in the case of a hemothorax, we have to be additionally attentive to clots in the tube themselves. So a clot in the tube of a patient who has a hemothorax can produce an emergency, because essentially that chest tube is occluded and is not able to serve the function that it is intended to serve. So that can create, as you can imagine, a major complication. This case study is here for you. We will discuss this in class. If you have questions, bring it to class. If you're watching this after, then you already have encountered the answers to this. So we will stop this lecture here, and we'll pick up from here with, as I stated, we'll pick up from here with the next lecture.